for giving us such an opportunity to present the topic. And also, adolescent gynecological oncology is a gray zone for the general gynecologist. I think it is due to two reasons. One is the incidence is relatively less. The number of cases we are seeing are less, and also the management modality, more of conservative management. We don't know how far we can go, and when we go for the terminal or the final management route. I think this webinar will clear all our doubts, and I wish all the success for this program. Thank you.
Thank you, Madam. Dr. Lalitambika, Madam, President Alappuzha Society. If she has joined, I invite her for a few words. I think she is not here. Dr. Anita Jacob, Madam, President Kollam Society. Okay, if they are joining late, we'll call them again. So I think we'll directly move on to the scientific session. Our first topic for today is epidemiology of tumors in adolescent, nuisances of diagnostic techniques and biopsy. First of all, I want to invite and welcome the expert for this session. It is none other than our dear Prasanna Kumari, Madam. I don't think we need any more explanation or invitation for her. She is the head of the department and senior consultant obstetrics and gynecology, Lifeline Hospital, Adur, senior consultant obstetrician and gynecologist, SUT Hospital, Trivandrum, former professor at Government Medical College, Calicut and Trivandrum, and she is the author of postgraduate gynecology. I think most of us have studied that textbook. She was awarded the WHO fellowship in 1991, the former president Kfog. I invite you, Madam, to say the expert comments about the topic. And I invite the speaker. She is Dr. Ambali Prakash from Adur. Over to you, Madam.
Respected Madam, Madam, and dear friends. So I'll be presenting the epidemiology of gynecological tumors in adolescents, nuisance of diagnostic techniques and biopsy. So the National Cancer Institute and European Network for the Cancer Research in Children and adolescents agree in defining the adolescents and adolescents' young age with the age range 15 to 39 years. Cancer is an important problem among the adolescents and young adults with a global annual incidence estimated at 1 million and a significant mortality. Over the last 30 years, cancer still remains the leading cause of disease death among people aged 15 to 24 years.
PowerPoint ആക്കാൻ പറ്റുന്നില്ലേ?
Slide. Madam.
Ambali ഹോസ്പിറ്റലാണോ?
അല്ല മാഡം, വീട്ടിലാ.
PowerPoint ആക്കിക്കേ.
മാഡം ഒന്ന് ട്രൈ ചെയ്യട്ടെ.
സ്ലൈഡ് ഷോ ഇല്ലെന്ന് ക്ലിക്ക് ചെയ്താൽ മതിയല്ലോ. ചിലപ്പോ സൂമിൽ ആവത്തില്ല.
Then കാണാം മാഡം?
കാണാം. ഓക്കെ.
Incidence of gynecological malignancy. The gynecological malignancies are the rare pediatric and the adolescent age group, and they may originate mainly from the ovary, but also from uterus, cervix, vagina, and vulva. So, considering this age group, special consideration has to be given regarding the impact of treatment on patients' physical and social development, body image, ovarian function, and fertility. So the most common gynecological tumor is the ovarian tumors. It includes both benign and malignant ovarian tumors, but they are rare in the pediatric population with an incidence which increases with age. First, about the benign ovarian tumors, it accounts for 60% of the cases. They include germ cell tumor, epithelial tumors, endometrioma, and gonadoblastoma. And the malignant tumors account for 4 to 16% of the cases. They include sex cord stromal tumors, germ cell tumors, and epithelial tumors. Sex cord stromal tumors include juvenile granulosa cell tumor, which is the most common, Sertoli ladies cell tumor. Germ cell tumors include dysgerminoma, yolk sac tumor, embryonal carcinoma, polyembryoma, and immature teratoma. These epithelial tumors are very rare, and they include serous cystadenocarcinoma and mucinous adenocarcinoma. Of these, the commonest gynecological tumor in an adolescent is ovarian germ cell tumor. These ovarian germ cell tumors are derived from the primordial germ cells of the ovary. They may be benign, example, mature teratoma, or malignant, that is immature teratoma, dysgerminoma, yolk sac tumor, or mixed germ cell neoplasm. This is the classification of germ cell tumors. That is, they can be, include teratoma, can be both mature and immature, monodermal tumors, dysgerminoma, yolk sac tumor, embryonal carcinoma, choriocarcinoma, and the polyembryoma. Then about the epidemiology, this ovarian germ cell tumors comprises approximately 20 to 25% of the ovarian neoplasms overall, but only account for about 5% of all the malignant ovarian neoplasms. They are found primarily in young females between 10 to 30 years of age, representing 70% of ovarian neoplasms in this age group. Worldwide, the incidence is the highest in the Eastern Asia for female less than 30 years and the highest in Central America for those more than 30 years. This among the malignant ovarian germ cell tumor, dysgerminoma, immature teratoma, yolk sac tumor, and the mixed germ cell tumors account for 90% of the cases. And the distribution is seen in this row, that is immature teratoma accounts for 35% of the cases, dysgerminoma 32%, yolk sac tumor 14%, mixed germ cell tumor 5%, embryonal carcinoma 4%, mature teratoma with malignant degeneration 2.9%, and choriocarcinoma 2.1%. Then about the clinical presentation, the patients can be asymptomatic. They can also present with abdominal enlargement. These ovarian germ cell tumors tend to grow rapidly, and abdominal enlargement may occur from the mass itself or ascites. These tend to be large, up to 16 centimeter, and ascites is reported in 20% of the cases. They can also present with pain abdomen. The pain abdomen results from either rupture or torsion. Rupture can occur in 20% of the cases, and the torsion is reported in 5% of the cases. And the pain may be an acute presentation and can be misdiagnosed as appendicitis. They can also present with precocious puberty, especially in granular cell tumor. They can also mimic the symptoms of pregnancy due to the production of HCG. Other symptoms like fever, vaginal bleeding occur in approximately 10% of the patients. This abdominal pain and the mass abdomen are present in almost majority of the cases, that is 85% of the patients with ovarian germ cell tumors. Then the signs and symptoms that are characteristic of a specific ovarian germ cell tumor. While most of the ovarian germ cell tumors present with non-specific signs and symptoms, some presentations, some of the presentations are more specific. For example, rupture of a mature teratoma with spillage of sebaceous material into the abdominal cavity, they can present with shock. By contrast, the monodermal teratoma, highly specialized teratoma, usually present with hyperthyroidism or carcinoid symptoms. The rare presentations include, that is, anti-NMDA receptor encephalitis is a rare condition associated with either mature or immature teratoma. These are the carcinoid symptoms that are seen in these germ cell tumors. That is flushing, telangiectasia, cyanosis, and pellagra due to the production of kinins or histamine, and diarrhea and the cramping due to the production of serotonin, valvular lesions due to the production of serotonin, and bronchoconstriction, that is causative agent is not known. Then about the diagnostic evaluation, this diagnostic evaluation is similar to that of the patients with other adnexal masses and include a complete detailed medical history and physical examination. About the imaging, as with other adnexal masses, pelvic ultrasound with Doppler is typically the first-line imaging study used to characterize an adnexal mass. Sensitivity ranges from 80 to 100%, and the specificity ranges from 94 to 99%. So this is the B rule and the M rule. That is a simple ultrasound rule to diagnose malignancy. That is IOTA rule. That is a B rule. That these are the features of benign lesions. That is unilocal cyst, presence of solid component with largest being less than 7 millimeter, presence of acoustic shadowing, smooth multilocular tumor with largest diameter less than 100 millimeter, and blood flow absent on Doppler. The M rules include irregular solid tumor, ascites, papillary structures, at least 4 should be present. Then irregular multilocular solid tumor with the largest diameter more than 100 millimeter and very strong blood flow present. So the rule 1 means malignant, that is if one or more M features are present in the absence of the B features. Rule 2 is benign, that is if one or more B features are present in the absence of the M features. Rule 3 means it is inconclusive, that is if both M features and B features are present, or if no B or M features are present, a second text like MRI is indicated. Then second diagnostic modality is tumor markers. That is, ovarian germ cell tumors often produce hormones which can be measured in the serum, providing a highly sensitive and variably specific marker for the presence of the certain histologic components. Some of the tumor markers are present in some, but not all, tumors of a specific histology. As an example, tumor markers produced by the tumor types may include HCG. That is, they are produced by embryonal cell carcinoma and ovarian choriocarcinoma, mixed germ cell tumors, and some dysgerminoma. Then alpha-fetoprotein is produced by yolk sac tumors, embryonal cell carcinoma, polyembryoma, mixed germ cell tumors, and some immature teratoma. Most of the dysgerminomas are associated with a normal AFP. This LDH is specifically produced by dysgerminoma. If elevated, the tumor markers are useful for monitoring the response to the treatment and also for post-treatment surveillance. And a pregnancy test should also be performed for all the reproductive age patients to exclude anectopic pregnancy or other pregnancy-related adnexal masses. Then the diagnosis of the ovarian germ cell tumors is made by the histology at the time of surgical excision, and the diagnosis is strongly suggested preoperatively by the presence of an adnexal mass on pelvic imaging and an elevated level of associated tumor marker. For a benign cystic mature teratoma, the diagnosis can be made with reasonable confidence using pelvic ultrasonography. However, removal of the cyst is still advised. Then a mature teratoma, that is the dermoid. Most of the teratoma are cystic, that is mature cystic teratoma, dermoid cyst. They are composed of mature differentiated elements, including tissues of ectodermal, mesodermal, and endodermal origin. The mechanism by which this is developed is possibly by the failure of meiosis II or from a pre-meiotic cell in which meiosis I has failed. In rare instances, a teratoma is solid, but it's composed entirely of benign appearing heterogeneous collections of tissue and organized structures derived from all the three cell layers. Mature cystic teratoma account for more than 95% of all the ovarian teratomas and are the most common ovarian tumor in females in the second and the third decade of life. This mature teratoma can also occur at non-ovarian sites like vaginal wall. They have also been described. The characteristic macroscopy appearance of a benign cystic teratoma is a multicystic mass that contains hair, teeth, and or skin that is mixed into sebaceous, thick, sticky, and often foul-smelling material. This is the appearance of dermoid cyst. There is a solid prominence, that is Rokitansky protuberance is also located at the junction between teratoma and the normal ovarian tissue. The greatest cellular variety is found in the area of this junction, which should therefore be examined carefully by the pathologist to exclude immature or malignant components. So most of the patients with mature teratoma are asymptomatic, and if present, symptoms depends upon the size of the mass. Torsion is not uncommon. Rupture of the dermoid cyst with spillage of the sebaceous material into the abdominal cavity can occur, but it is uncommon. Shock and hemorrhage are the immediate sequelae of the rupture. A marked granulomatous reaction may subsequently develop and lead to the formation of dense adhesions. Most of the mature solid teratoma are unilateral. Bilateral mature teratoma occur in 10 to 17% of the cases and can be synchronous and metachronous. Peritoneal implants have also been described. Grossly, it may be difficult or impossible to differentiate these neoplasms from malignant solid immature teratoma, which are almost always solid, and they therefore may require sampling from multiple sites. Then about the malignant transformation. This mature teratoma are almost always benign. Development of the malignant neoplasms occur in 0.2 to 2% of the mature cystic teratoma and comprises 2.9% of all the malignant ovarian germ cell tumors. Although any of the components of the mature cystic teratoma may develop malignant neoplasm, this squamous cell carcinoma arising from the ectoderm is the most common secondary neoplasm. When the malignant transformation has occurred within a teratoma, treatment must be tailored to the transformed histology. These risk factors for the malignant neoplasm in a mature cystic teratoma include age over 45 years, mean age 50 years, then tumor, large size of the tumor, that is diameter more than 10 centimeter, rapid growth, and characteristic findings on imaging, that is low resistance tumor flow on Doppler. Then about the immature teratoma, this immature teratoma, also called the malignant teratoma or the embryonal teratoma, they comprise less than 1% of the ovarian teratomas and are most common in the first 2 decades of life. They comprise 35% of all the malignant ovarian germ cell tumors. This immature teratoma is typically composed of tissue from the 3 germ cell layers, that is ectoderm, mesoderm, and endoderm, arranged in a haphazard manner. Histologically, there are varying amount of immature tissue, most frequently with neural differentiation, although immature stromal elements can also be present. This immature teratoma are the only ovarian germ cell tumor that are histologically graded. The grade of differentiation is based upon the proportion of the tissue in the histology section containing the immature neural elements. This grade is an important indicator of the risk for extra-ovarian spread. The presence of the foci of yolk sac tumor in immature teratoma generally reflects more aggressive behavior and a worse outcome. In this role of biopsy, that is image-guided biopsy using the ultrasound or CT guidance is of value in planning the management of suspected ovarian cancer and peritoneal carcinomatosis of uncertain etiology. Actually, it provides a site-specific primary tumor diagnosis in 93% of the cases, and it should replace the diagnostic laparoscopy or laparotomy for this purpose. It also allows the provision of the primary chemotherapy based on a firm histologic diagnosis. Finally, it is a valuable problem-solving tool in situations of diagnostic uncertainty. Example, unusual imaging patterns of disease such as peritoneal carcinomatosis with bilateral solid ovarian masses or non-enlarged ovaries and with an unusual tumor marker profiles, suggesting the primary tumors out with the ovary. The technique is simple, safe, and effective and can be combined with palliative drainage of the ascites at the same procedure. Then about the rare gynecological tumors, that is uterine tumors. Only a few cases of endometrial carcinoma have been reported in the adolescents, and this uterine sarcoma represents 3 to 9% of the malignant uterine tumors. These main histology categories of uterine sarcoma are leiomyosarcoma, carcinosarcoma, and the endometrial stromal sarcoma. Very few cases include vascular and lymphatic sarcoma. So this rarity of the uterine sarcoma has made it difficult to identify the risk factors. But it is found that it is associated with certain hereditary conditions like hereditary leiomyomatosis and renal cell carcinoma syndrome. This long-term and also in cases of long-term survivors of childhood retinoblastoma. So the clinical presentation, it can also be asymptomatic and can also present with pain abdomen, abdominal distension, urinary symptoms. And on physical examination findings, they are very similar to that of an uterine leiomyoma. On USG, there are focal masses within the tumors, and the features that are suggestive of the sarcoma include mixed echogenic and poor echogenic parts with central necrosis. And on color Doppler, there will be irregular vessel distribution, with low impedance flow and high peak systolic velocity. Then the other rare tumor, that is rhabdomyosarcoma in the childhood and the adolescents. That is nearly 80% of the genitourinary tract rhabdomyosarcoma are embryonal. This botryoid variant, a unique form of embryonal rhabdomyosarcoma arising within the wall of the bladder or vagina, is seen almost exclusively in infants. About the etiology, this etiology and specific risk factors are not known. A few reports suggest a higher incidence in individuals exposed to radiation in utero, children from families with a low socioeconomic status, children with certain congenital anomalies, and preterm birth, and more likely to develop rhabdomyosarcoma. This and with certain inherited syndromes, that is, they are mostly sporadic and can also 5 to 10% of the cases will be associated with inherited syndromes like neurofibromatosis, Lee-Fromeni syndrome, and Costello syndrome. Individuals with cancer predisposition are generally younger at diagnosis, although 40% were more than 3 years of age. So this genetic testing should not be limited to less than 3 years of age. About the tissue diagnosis, adequate tissue for routine light microscopic immunohistochemistry, cytogenetic, and molecular genetic studies should be obtained at the time of biopsy or initial resection. If possible, the initial diagnostic biopsy should be performed at a facility with expertise to ensure that the tissue is processed properly. This classification of the tumor as rhabdomyosarcoma requires identification of features of the skeletal muscle lineage. Typically, this involves light microscopic identification of the rhabdomyoblast. For cases that lack these features, immunohistochemistry staining or electron microscopy may provide evidence supporting myogenic differentiation. So last about the immunohistochemistry, it is a reliable method for identifying muscle-specific proteins such as actin, myosin, desmin, myoglobin, and Z-band protein. So this is in short about epidemiology and various diagnostic modalities.
Thank you, Ambali. It was very exhaustive.
Thank you, madam.
It was very exhaustive. But the thing is,
Yes, madam.
whenever an adolescent is seen to have a mass abdomen, it should be properly evaluated, especially
Yes,
with the tumor markers, and it should be properly treated. It should not be treated in a primary care center, and ideally, she should be referred to the oncologist.
Yes, madam.
She should be referred to the oncologist. And one thing is, there are so many clinical scenarios which come to my mind is this yolk sac tumor. Yolk sac tumor usually presents as in an acute state with fever. With fever, they will present usually, and they can present with rupture also. It will be like ഒരു പുഡിങ് പോലെ ഇരിക്കും കണ്ടാൽ യോക് സാക് ട്യൂമർ ഇങ്ങനെ ചുമന്ന് ഇരിക്കുന്ന ഒരു ജാം പോലെ. അപ്പൊ അത് റപ്ചർ ചെയ്യാം, പിന്നെ ഫീവർ ആയിട്ട് പ്രസന്റ് ചെയ്യാം. മേ ബി റപ്ചർ ചെയ്യുന്നോണ്ടായിരിക്കണം ഫീവർ ആയിട്ട് പ്രസന്റ് ചെയ്യുന്നത്. പിന്നെ ഓൾ ദീസ് germ cell tumors have good prognosis and they are all amenable for conservative management. അതുകൊണ്ട് so they should be managed properly in a tertiary level care, ideally by oncologists. And when it even the cystic teratoma, it can be bilateral, it can recur. So if you find cystic teratoma or dermoid in one ovary, the ovary can undergo torsion, and then somebody will be removing the ovary and the tube, and she develops another cystic teratoma on the other side. So that can also undergo torsion. So if you find cystic teratoma, especially in younger women or children, it should be managed. It can be easily managed by cystectomy laparoscopically. Otherwise, it can affect your fertility. We don't think of fertility preserving surgeries or methods when a young girl or adolescent comes with the dermoid cyst, but it can lead on to infertility in later life. One adnexa torsion, I remember 1 or 2 patients like that. One adnexa removed, the entire adnexa removed with torsion. And another thing is that even if it undergoes torsion, if you do untorsion, detorsion laparoscopically and wait, it will the blood flow will come and they can conservatively manage. You need not do an adnexectomy. And if it comes on the opposite, see, one patient whom I saw, 1 or 2, one adnexa was removed because it was torsion, and the other side she came with another dermoid cyst. So then the question of fertility preservation comes, and all these germ cell tumors are can be managed by conservative management, even if it's stage 3. Conservative management, and we have to think of fertility preservation, which will be dealt with in detail in the coming talk. So always think of that possibility, and it should be managed by a multidisciplinary team, including fertility specialists, oncologists, and the geneticist. Sometimes, there can be an XY female. An XY female, she actually, it's a he, can present with a solid tumor on one side. And unless you think that the possibility that she's not attained menarche and it could be some XY female, we have to remove the other gonad also, even if it's not affected, because other gonad also will go in for malignancy. There are so many situations like this, and we have to do the karyotype, etc. If a premenarchal girl comes also, we have to think of all these possibilities. So the fertility preservation is coming up now, the next talk. So thank you, Ambali.
Thank you, madam.
Thank you, Prasanna Kumari, madam.
Then
And thank
Ambali
you,
was talking
Dr.
about the
Ambali, for a very
M rule and M rule and
beautiful discussion.
P rule.
Yes,
Actually,
madam.
the iota next classification, which is more definite, when somebody is not that much familiar with the ultrasound picture of a malignancy or benign, it should be put in the iota at next model and sort out whether it is benign or malignant, rather than managing in a primary care center by removing the ovary. Okay, proceed, Suma.
Thank you, madam. Dr. Sujita, madam, has joined us. Madam is the state coordinator of our Kfog webinar series. She is the president-elect of Kfog. I welcome you, ma'am, to this webinar series, and I welcome you for a few words.
Thank you so much, Suma. Actually, I had a emergency call. That's why I ran. I remembered this program.
It's okay, madam.
So
happy that you have joined, madam.
our Dr. Mini is synonymous with adolescents nowadays because she has taken programs. That's something very wonderful. So when she undertook this, she has really made a real change. And I'm so happy that this last seminar is on the tumors in adolescent girls because very often we see girls with tumors and we don't know what to do next. So it's very informative, and I was just listening to the talk just prior to this. Excellent. So thank you so much for this opportunity, and I really appreciate our President Dr. Kunjumoideen for creating this webinars. It's been a wonderful experience. So thank you, Suma, for inviting me to say a few words. Okay.
Thank you, madam. Thank you so much. So we'll move to the next session. Our next topic for today is effective management of gynecological tumors in adolescents. I invite the expert for this session, Dr. Jayashree Vaman. She is known to all of us. She is the professor, Government Medical College, Trivandrum. She has 27 years of teaching experience in various government medical colleges, both undergraduate and postgraduate. She served as the organizing secretary 2 years for the Trivandrum ONG Society, nodal officer Lakshya, and she has many publications to be with her. And she has special interest in gynec-oncology and laparoscopy. I invite you as the expert for the next session, madam. I invite the speaker, Dr. Arya S. She is the junior resident, Government Medical College, Kottayam. Over to you, ma'am. Arya?
Hello, madam.
Yes. You can share your slides.
Okay.
Is there any difficulty?
Arya.
Is it visible now?
No.
No.
You have to click the share screen button.
Share screen. You need any help?
Yes, madam.
Just try and
There's a green small square area with an upward arrow. You click on that.
Yes, I have clicked it, madam. എനിക്ക് സ്ലൈഡ്സ് വരുന്നുണ്ട് പക്ഷെ അത് പ്ലേ ആവുന്നതായിട്ട് കാണുന്നില്ല.
സ്ലൈഡ്സ് ഏക്ക് കാണാമോ?
എനിക്ക് വരുന്നുണ്ട്.
ഞാൻ ഷെയർ ചെയ്യാം.
ഒന്ന് ഷെയർ ചെയ്ത് കൊടുക്കുവോ?
ഞാൻ ഷെയർ ചെയ്യും. കാണാമോ?
സ്ലൈഡ് ഷോ ഒക്കെ
yes.
ഇപ്പൊ കാണാം ആര്യ.
ആര്യ പറഞ്ഞോളൂ.
ആര്യ ഇത് നോക്കി പറഞ്ഞോളൂ.
ആര്യ
Hello.
ആ
Madam.
കാണുന്നില്ലേ?
Okay, madam. I am presenting the topic effective management of gynecological tumors in adolescents. Abdominal masses in the pediatric population most commonly derive from the ovaries, and it ranges from simple functional cysts to malignant neoplasms, and the incidence of ovarian malignancy is 3 to 8%. Functional masses increase after menarche, and the risk of malignant neoplasm is lower in adolescent than younger children. Coming to the management part per se of benign ovarian tumors, pediatric patients have a long life expectancy after treatment. So the preservation of gonadal function is important for fertility maintenance as well as for natural progression of puberty. And they are also worried about the abdominal scars, which causes the psychological issues and decreased self-confidence in young girls. Hence, the management of ovarian masses in children and adolescents should be curative and whenever feasible, function preserving and minimally invasive, which is achieved through a laparoscopic ovary preserving surgery. Pediatric patients with ovarian masses should be treated with specialized centers to ensure the best possible outcome. The management of simple ovarian cyst, cyst less than 3 centimeter, only the evaluation not needed. 3 to 7 centimeter simple cyst, follow-up after 6 weeks is needed to differentiate between functional cyst and benign tumors such as serous cystadenoma. If cyst persists more than 10 weeks, laparoscopic cystectomy may be warranted. Hemorrhagic cyst, rescan is needed in 6 to 8 weeks to differentiate between corpus luteal hemorrhage from endometrioma. A cyst more than 7 to 8 centimeter needs surgical removal, laparoscopic cystectomy. Complex cyst less than 5 centimeter needs follow-up with ultrasonography every 6 to 12 weeks. 5 to 7 centimeter size complex cyst needs laparoscopic cystectomy. And if the size is more than 7 centimeter, detailed evaluation by CT or MRI is needed. And in case of ovarian torsion, detorsion rather than oophorectomy dermoid cyst of any size needs surgical intervention by laparoscopic cystectomy. Chance of chemical peritonitis following intraoperative rupture is there. So in case of any event of rupture, thorough peritoneal lavage is must. During laparoscopy, endobag used to prevent spillage. Coming to malignant ovarian tumors, and it is very rare as in adolescents. Significant impact on the survival and future fertility and quality of life in case of malignant ovarian tumors. And its management is complex and requires expertise and careful planning. And all guidelines recommend a thorough diagnostic workup, immunohistochemical methods to confirm the diagnosis, assessment of prognostic factors, and complete surgical staging. Treatment include both surgery and adjuvant therapies, mainly chemotherapy. Choice of surgical approach is based on preoperative imaging and avoiding all intraoperative tumor rupture. And great emphasis on fertility preservation when it is oncologically safe and regular and long-term follow-up is practiced. In case of high suspicion of malignancy, median laparotomy is indicated. And in children, a subumbilical transverse incision or a phalansteal laparotomy can also be accepted, depending on the size of the tumor and the initial tumor spread. Minimally invasive approach is an acceptable alternative only if the surgeon is experienced and properly trained in laparoscopic oncological surgery. Regarding the radicality, oophorectomy should be preferred compared to cystectomy in ovarian malignancy, and oocyte cryopreservation should be offered to all patients scheduled to receive chemotherapy. Young patients treated with chemotherapy and offered hormone replacement to relieve symptoms of estrogen deficiency. Regular targeted and long-term follow-up is essential in case of malignancy.
Postoperative measurement of serum tumor markers and ultrasonography to assess the tumor response during chemotherapy. Pelvic ultrasound done every 6 monthly. CT scan only upon clinical indications. PET scan is never used as a tool for follow-up. In germ cell tumors, for solid unilateral tumors, total en bloc oophorectomy is recommended. Cystectomy should be avoided in case of a cystic tumor. And when both ovaries are macroscopically involved, bilateral oophorectomy should always be avoided if possible. That means the maximal effort to preserve at least one part of ovary and the uterus is encouraged, even in stage 1B tumors, except when genetic analysis is suggestive of dysgenetic gonads. Genetic analysis and counseling offered in all patients with bilateral ovarian tumors to identify sex chromosomal aberrations accompanied by dysgenetic gonads. In those cases, bilateral salpingo oophorectomy is needed due to risk of gonadoblastoma or dysgerminoma. Lymphadenectomy reserved only in cases with intraoperative evidence of lymph node involvement. Adjuvant chemotherapy, most used combination is 5-day therapy of BEP regimen. Fertility sparing surgery should be considered even in patients with advanced stage disease due to high chemosensitivity of malignant granulosa cell tumors. Adjuvant chemotherapy for all patients with advanced stage disease. Extensive cytoreductive surgery, which pose delays in commencement of postoperative chemo and increased long-term morbidity, should be avoided in adolescent age group. And platinum-based chemotherapy, mainly the BEP regimen, remain the treatment of choice. A second surgical resection is not always necessary, and it is only recommended in real disease. Dysgerminoma, there will be a bilateral disease in 10 to 15% cases and can spread to the retroperitoneal lymph nodes. During staging, the biopsy of contralateral ovary is not encouraged if it appears to be macroscopically normal. There clinically, bilateral, the contralateral ovary should be examined, and if appears normal, should not be biopsied. Active surveillance can be applied for stage 1A. In stage 1B to 1C, with complete surgical resection, active surveillance or an alternative of adjuvant chemotherapy can be used. It has an excellent prognosis. For immature teratoma, stage 1 or 2 disease, complete surgical resection can be used, or post-operative chemotherapy do not decrease the risk of relapse. Active surveillance is recommended for stage 1A to 1C3 grade 1 tumors, and for grade 2, alternative of adjuvant chemotherapy can be used. 5-year survival rate 91%. And tumors are usually aggressive. Peritoneal, hematogenous, and lymphatic metastasis is seen. Most cases treated with conservative surgery and multi-agent chemotherapy. Properly staged patients with stage 1A and potentially 1B and negative postoperative tumor markers monitored with active surveillance. Prognosis depends on stage of the disease. For stromal tumors, complete surgical staging is important. That sampling, unilateral adnexectomy, examination of contralateral ovary, large segmental biopsy, or infracoronary omentectomy, peritoneal sampling, and resection of any suspicious lesions. Total hysterectomy as a part of initial surgery should only be performed in patients with 2 or more. Omentectomy recommended only in cases with adhesions to omentum and not as a routine procedure. Lymphadenectomy not recommended, but excision of lymph nodes with intraoperative enlargement of node C. Patients with confirmed stage 1A disease should be treated only with surgery. Tumors higher than 1A may require chemotherapy, mainly BEP regimen. Granulosa cell tumors in early stage disease limited to ovary. Excellent prognosis with survival rate of over 90% with surgery alone. Patients with stage 1A to 1C1 disease complete surgical resection and may avoid chemotherapy, and chemotherapy may be required for stages 1, C1, 2 to C3. And take home message is adolescent ovarian tumors is ovarian malignant tumors is very less. For benign tumors, whenever possible, try with go on with cystectomy rather than oophorectomy. And in malignant, in ovarian torsion, detorsion is preferred than oophorectomy. And in malignant ovarian tumors, the fertility preservation is needed, and so that we can go on with oophorectomy, and whenever possible, bilateral Salpingi oophorectomy is avoided, and at least a part of one ovary. And in cases of malignant tumors where bilateral VSO is required, oocyte cryopreservation should be offered. And in germ cell tumors with that bilateral tumors, cystectomy should be they should be given genetic analysis counseling. Thank you.
Good evening. First, let me congratulate the whole team, Kfog, for conducting, and the team leader, Kunju Moidin sir, for carrying out this webinar series. And also, I would like to thank Dr. Mini Balakrishnan for making me a part of this webinar series. And also, I would like to thank Arya for this wonderful presentation. Actually, she has covered the whole of management of, including the benign and the malignant conditions, gynecological conditions which can occur in the adolescent age group. And it was really, I should say, it was very informative and engaging talk that she has done. And I don't have much to add because she has talked upon and touched upon each and every aspect of benign and malignant condition. But one thing we often forget when we handle, because most of the time the adolescent girls, the symptoms are overlooked many a times because sometimes they may present with urinary symptoms or mild abdominal pain. And most of the time, the mother will be reluctant to bring these girls to a gynecologist. That's what I have often observed. And another thing is now I think the trend has changed whenever we come across ovarian torsion when she's taken for a laparoscopy or a laparotomy. As far as possible, even if the color has changed, I don't think we have to proceed with an ovariotomy. Always try for a detorsion and wait for some time, and you can do a cystectomy, or some just a detorsion alone may sometimes help when the ovary alone has undergone a torsion. So I think that's a great change because we are from radicality, we have changed to more of a conservative management. And imaging studies, which I need to stress upon because most of the gynecologists should be familiar. All of us should be familiar with the pattern recognition to identify which is totally benign and which could be malignant. So when we have a suspicion of malignant cases, I think we have to refer those cases to tertiary care center where a proper counseling can be given to the patient and it can be managed, because majority of the tumors in the adolescent age group, it's more of non-epithelial tumors, and even if it is malignant, it has an excellent chemotherapeutic agents are available. Actually, the tumor melts with a, so in case we come across a tumor accidentally, we happen to open without a workup properly, and you come across solid tumors. Don't ever go with a complete radicality in surgery. We can offer conservative management, and after receiving the histopathology, we can go with a chemotherapy if required, if it turns out to be malignant. And another thing is, so always you have to stress that the fertility sparing option, because the mother and the girl will be worried if she comes to know that there is something malignancy in the ovary. We have to tell them that we will be doing fertility preservation surgery, and also the option of cryopreservation of the ovarian tissue, the possibility of ovarian cryopreservation, even oocyte cryopreservation, you can do it. So all these things we have to discuss, and at the end, I think the most important is the quality of life and the psychosocial support as a gynecologist, which we should offer all these women, all these girls who will end up with us. So thank you so much for making me a part of this webinar, and the talk was excellent, I should say.
Thank you so much, madam. That was a wonderful session by Dr. Jayasri madam and Dr. Arya. I think the gynecological tumors in young girls, it is a very important topic which should be made aware to all the obstetricians, because the first person who is counseling the patient will be the most important person in their life. So the initial counseling is very important. So I think it's a very relevant topic in today's practice. Thank you so much, madam.
One,
And
one,
Arya.
one thing I just want to see, because most of the time when we come across dermoid, just a sentence about it, because we may think that when the patient is not having any symptom, I think that girl need to be operated. Though we talk about this NMDA receptor encephalitis being a rare thing, but I have seen 5 to 6 cases where they landed up in the neurology and some in the psychiatry department with the psychiatric symptoms. And so I think that possibility has to be kept in mind. One practical point which I need to tell.
Even
Okay, madam.
otherwise, this dermoid should be removed. I have
Yeah.
seen adolescents with distal dermoid, and somewhere adnexectomy has been done. So fertility preservation is important in that case also. And
Yeah.
comes to ovarian tumor, all these germ cell tumors, usually they are, even if they are very big and stage 3,
Yeah.
they unilateral, and we'll go for a stage 3 conservative management. And this BEP regime, etc., will reduce the ovarian reserve. So oocyte preservation,
Very
because
important.
they're adolescent, we can't think of embryo preservation. Oocyte preservation and then in vitro maturation. That is can be
Yeah.
done. We are doing it. So that should be thought of. Ovarian preservation, നമ്മളങ്ങനെ ഇതുവരെ ചെയ്തിട്ടില്ല.
Because there are a lot of issues with that, because it's already a malignant cell, but they're talking about ovarian cryopreservation as well in case of this.
Oocyte preservation ചെയ്യാം. Oocyte preserve ചെയ്തിട്ട് പിന്നെ in vitro maturation, and we have to think about it.
I think
Gynecologists should be sensitized to this preservation of
the
fertility
council.
counseling, and especially about when a young girl comes, it can be XY. So we have to remove the hormone, and otherwise we need not. So all these things should be kept in mind. As JC said, it should be referred to a tertiary center where all this can be managed away. A nice topic selection, Kunjumedin. Kunjumedin boyo.
Mini madam is here, madam.
Actually, sir only has designed all these program schedules, the topics, each and everything he has selected.
The initial one was episiotomy, isn't it?
Epidemiology. Yeah, first one. Yeah.
Episiotomy. And Jish told me, I was in the postoperative period. I said, episiotomy, then I will join. and that is a very nice webinar, episiotomy.
Yeah. And അത് കുറേ നീണ്ടുപോയി അന്ന് നല്ല ഡിസ്കഷൻ ഞാൻ ഒരു സിമ്പിൾ എപ്പിസോഡ് that discussion has gone to such an extent.
So many points were brought out, and എല്ലാവരും നല്ലതായിട്ട് പ്രസന്റ് ചെയ്യുകയും ചെയ്തു. ലാസ്റ്റ് വെബിനാർ ഞാൻ ഉണ്ടായിരുന്നല്ലോ, എന്തുവായിരുന്നു, ഞാൻ മറന്നുപോയി. സി എൻഡോമെട്രിയം. That was also nice. സി എൻഡോമെട്രിയം.
ശരിക്കും നമ്മൾ if we go to conference we cannot reach each halls. Every topic will be in different halls. Actually we feel like listening to each one, but unfortunately we can't because it is simultaneously conducted. So these sort of webinars actually provide us to have an opportunity to hear.
കുഞ്ഞുമോദിന് നല്ല ഐഡിയ ആണ്. ആദ്യം പിന്നെ പെരിന്തൽമണ്ണ സൊസൈറ്റി തുടങ്ങിയപ്പോൾ ഞാൻ അന്ന് അതിശയിച്ചു. ഒരു വർഷം നല്ല അക്കാഡമിക് ഫീസ്റ്റ് ആയിരുന്നു. I so much appreciated Kunjumedi. Thank you, Minnie, for inviting me.
And madamനോട് ഒത്തിരി താങ്ക്സ് ബിക്കോസ് ഈവൻ ഇൻ എന്താ പറയാ കോൺഫറൻസിന്റെ മാഡം സ്റ്റാർ ആണ് യങ് ടാലന്റിന്റെ ആൻഡ് ഇൻസ്പൈറ്റ് ഓഫ് സച്ച് എ ബിസി ഷെഡ്യൂൾ മാഡം വന്ന് ചോദിച്ചു അഗ്രി ചെയ്തതിൽ എനിക്ക് ഒത്തിരി
ജോലിയിൽ ബിസിയാ ലൈഫ് ലൈനിൽ, വേറൊന്നും ചിന്തിക്കാൻ പറ്റത്തില്ല. അത് ഇപ്പൊ അധികം അങ്ങനെ സർജറി ഇല്ലെങ്കിലും ബിസിയാണ്.
നമുക്ക് ഒത്തിരി 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 താങ്ക്സ് മാഡം.
താങ്ക് യു മിനി, മിനിയൊക്കെ കണ്ടതിൽ സന്തോഷം.
കാണാം മാഡം, അടുത്ത ആഴ്ച കാണാം എല്ലാവരും.
കോൺഫറൻസിനാ കാണുന്നത്.
കാണാം, എല്ലാരും വരും.
ഉണ്ട് പ്രാവശ്യം ട്രിവാൻഡ്രത്ത് തന്നെയല്ലേ. ഓക്കെ, സോ നെക്സ്റ്റ് ടോപ്പിക്കും കൂടെ കഴിഞ്ഞാൽ
Yes, we'll move on to our last session. Our last session for today is role of conservative and fertility preservative surgeries and advances in targeted therapies. To express the expert comments, I invite Dr. Anu N. Joseph. She is a consultant gynecologic oncologist affiliated to Mithura Hospital, SH Medical Center, Bharat Hospitals and Medical College, Kottayam. I welcome you, ma'am. And to present the topic, I invite Dr. Sai Lakshmi from Travancore Medical College. Over to you, ma'am.
Good evening, ma'am. Am I audible, ma'am?
Yes, we can hear.
Okay, ma'am. So the topic of discussion is role of fertility preserving surgeries and advances in targeted therapy. So first, a small introduction. So gynecological tract lesions in children and adolescents are rare. They are representing less than 5% of all pediatric tumor. So most common primary site is ovary, followed by vagina and cervix, then uterus and the vulva. The ovarian tumors mostly occur in adults and rare in adolescent young adult population with an estimated annual incidence of 2.6 per 1 lakh population. Among ovarian tumors, 10% to 30% are malignant and account for 60 to 70% of all pediatric gynecologic malignancy. When compared with adult, germ cell and sex cord stromal tumors are more frequent in this age group. First, about uterine tumors in adolescents. So, uterine tumors are rare. They are more likely malignant in this age group. So, only a few cases of endometrial cancer have been reported in adolescents. Uterine sarcoma represents about 3 to 9% of all malignant uterine tumors. Traditionally, histologic categories of uterine sarcoma are leiomyosarcoma, about 40%, carcinosarcoma, about 40%, and endometrial stromal sarcoma, which are about 15%. The remaining 5% of cases consist of heterogeneous group of vascular and lymphatic sarcomas. So, uterine leiomyosarcoma may occur in younger women and premenopausal patients. Still, uterine leiomyosarcoma is very rare during childhood and adolescence. Then vaginal and cervical tumors in adolescent. In this age group, most common neoplasm of lower genital tract is the sarcoma botryoides, followed by endodermal sinus tumors. So it's a rare embryonal variety of rhabdomyosarcoma, usually found in vagina of infants and early childhood. So onset is from the uterine cervix is very rare, with a peak incidence in second decade of life. These lesions are usually clinically visible with a nodular and grape-like mass which protrudes from the vagina. Next, about ovarian tumors, which are most common, which are most common in pediatric age, adolescent age group. So, sex cord stromal and germ cell tumors are common in adolescent age group. So, juvenile granulosa cell tumor accounts about 70% of all ovarian sex cord stromal tumors in patients less than 20 years. So approximately 80% of prepubertal girls with juvenile granulosa cell tumor present associated with precocious puberty related to estrogen secretions. Rarely the tumor produces androgen and causes virilizing features. In children with juvenile granulosa cell tumor, mostly associated with acute complications such as torsion and rupture. In germ cell tumors divided into two groups, seminomas and non-seminomas. Dysseminoma is the most frequent ovarian malignant germ cell tumor observed during the adolescent. Yolk sac tumor is a second most common malignant entity in young population, usually aggressive with growth and extensive spread to abdominopelvic cavity. Hematogenous and peritoneal mets and lymphatic spread are usually observed. Next is teratoma, which are mature and immature. Dermocyst is the most common benign ovarian tumor found in adolescent, and immature teratoma frequently occurs between the first and second decade of life, which represent 10 to 20% of all ovarian malignancies in patients younger than 20 years. It shows aggressive behavior and worse prognosis than the mature teratoma. So the current treatment of choice of immature teratoma is surgery alone with the unilateral salpingo-oophorectomy and the staging procedure. So the model of care for adolescents and adolescent young adult gynecological tumors are education of primary health care for reducing the referral time to the oncologist, optimization of the clinical environment with dedicated spaces, psychosocial support for enhancing adherence to the treatment, enrollment in clinical trials for cancer based on the 5A, and multidisciplinary tumor board and national cooperative research group. The 5 A's in the model of care are appropriateness of age inclusion criteria, availability of new agents for clinical trials, trials, accessibility to clinical trials in all treatment centers, awareness of adolescent young adult cancers by drug developers, and acceptability of trial design and research questions, both the patients and healthcare professionals. So, how surgical treatment affects the fertility? In women, there is loss of menstrual cycle or premature menopause, and diminished ovarian reserve, and likelihood of pregnancy remains low. So, what is fertility preservation? It's a process of saving gametes, egg and sperm, or reproductive tissue, so that a person can use them to have a biological children in the future. It's a new field in reproductive medicine. Who can benefit from fertility preservation? Patients with malignant disease, that is, people who need to be treated for cancer, and patients with benign diseases like endometriosis, rheumatoid arthritis, and lupus, and those who have exposure to toxic chemicals and genetic disease that affect the fertility, and patients with social reason, that is, people wanting to delay having children. So, in benign disease, it compromises the ovarian reserve due to mechanisms related to the pathology itself or secondary to the preformed treatment. So, the gynecological diseases include endometriosis, ovarian cyst, and borderline tumors. So, there will be depletion of the ovarian reserve as a result of repeated ovarian surgery and direct damage to the ovarian reserve with different mechanisms like focal inflammation, destruction of surrounding normal cortex, fibrosis, and loss of cortex-specific stroma, and enhanced follicular recruitment and atresia. In malignancy, there will be it affect by removal of organ, change in hormone level, and damage to the oocyte or sperm, which will decrease the fertility. And the treatment side effects, like in chemotherapy and in radiotherapy, there will be premature ovarian failure. It's a reduction of primordial follicle pole, and ovarian atrophy can occur, fibrosis of ovarian cortex, and damage to the gonadal vascularization. All depends on the type, dose, and duration of the treatment. So the fertility preserving surgical options in gynecology. So localized gynecological cancer can be challenging because of the desire to maintain reproductive function. So there should be counsel regarding the indication and the limitation of the fertility preserving treatment. In ovarian lesions, like in dermoids, cystectomy is preferred. So minimal in laparoscopy, minimal cautery should be used, proper peeling of the cyst wall, minimal manipulation, minimal spillage of the contents, and preservation of the ovarian tissue. Then in immature teratoma, in reproductive age group, typically confined to a single ovary, therefore unilateral oophorectomy and fertility sparing surgical staging should be performed. Contralateral involvement is rare, and routine resection or wedge biopsy of contralateral ovary is unnecessary. In carcinoma ovary, that is an epithelial ovarian tumor, stage 1 and stage 1A and 1C, unilateral salpingo oophorectomy with adequate staging is preferred. In borderline ovarian tumor also, unilateral salpingo oophorectomy with adequate staging or ovarian cystectomy can be done. But in ovarian cystectomy, the recurrence is high. In germ cell tumor like dysseminoma, minimal surgical operation is unilateral oophorectomy. If there is a desire to preserve fertility, as there almost always is a contralateral ovary, fallopian tube, and uterus should be left in situ, even in the presence of metastatic disease, because of the sensitivity of tumor to the chemotherapy. In yolk sac tumor, unilateral salpingo oophorectomy and frozen section is done for the diagnosis. In carcinoma cervix, early stage like stage A and stage 1B1, radical trachelectomy with lymphadenectomy is preferred, and transposition of ovaries outside the pelvis during post-operative radiotherapy. In stage 1A, conization or LEDs can be used. In endometrial carcinoma, stage 1 in young woman, high-dose progesterone can be given. So the fertility preserving options are medical therapy, GnRH agonist. So its goal is to shut down the ovaries during cancer treatment in order to protect them from damaging effects. In reducing activity in the ovaries during treatment, will reduce the number of eggs that are damaged, will resume normal cycle after treatment. Should not be considered a proven fertility preserving method. It can be offered if proven fertility preserving method are not feasible. Next is oocyte cryopreservation or egg freezing. For women who do not have a partner who want to delay marriage or pregnancy for career-related reasons. Process of egg collection usually takes 10 to 14 days, depending on her menstrual cycle. hormonal treatment for about 8 to 14 days to allow several eggs to develop in the ovaries at once. Ultrasound monitoring of follicles is done 3 to 5 times during the process. Egg retrieval is with a needle under ultrasound guidance through the vagina and into the ovary. Double stimulation can be used as a new stimulation protocol. In both follicular and luteal phase of same menstrual cycle have been proposed. Aim is to maximizing the number of oocyte retrieved in the single cycle. Then cryopreservation of ovarian tissue. It is done in prepubertal patients with cancer and women who cannot delay the onset of their treatment and patients with benign pathologies with the risk of premature ovarian failure and patients with clinical symptoms of premature ovarian failure like amenorrhea, oligomenorrhea, high FSH levels, very low AMH level, decreased ovarian volume, and follicle count nearly zero, and postponing menopause. The whole ovary or part of ovary is surgically removed. Medulla is removed and cortex is trimmed to a thickness of 1 to 2 millimeter. It cut into pieces with an area of 5 into 5 millimeter and pieces of cortex equilibrate in cold freezing solution for 30 minutes on ice. Transferred to individual cryotubes and slow frozen in the liquid nitrogen. Stored in liquid nitrogen until the time of reimplantation. Then in vitro maturation or artificial ovary. Isolate and transplant primordial and primary follicles, avoiding inadvertent contamination by malignant cells, possibly present in the ovarian tissue. So follicles are enclosed in the basement membrane that avoids direct interaction between the follicular cells and capillaries, WBC, and nerve processes. Their isolation will guarantee that no malignant cells are returned back into the patients. Next is targeted therapy. It's a type of cancer treatment that uses drugs designed to target cancer cells without affecting normal cells. So cancer cells typically have changes in their genes. So targeted drugs can block or turn off signals that make cancer cells grow or can signal the cancer cells to destroy themselves, which includes anti-angiogenic inhibitors, PARP inhibitors, drugs that target folate receptor alpha, drugs that target cells with NTRK gene changes, and immunotherapy. So angiogenic inhibitors, they are monoclonal antibodies. Angiogenesis is essential for the tumor growth and development. Mechanism is inhibition of circulating pro-angiogenic factors like VEGF and VEGF receptors, downstream signaling of pathways involved in angiogenesis, and block the formation of new blood vessels that feed and nourish the cancer cells. Antigenic inhibitor is bevacizumab. It's a monoclonal antibody against VEGF-A, which was first approved. The pazopanib is an oral VEGF receptor blocker and platelet-derived growth factor blocker. Indaparib is VEGF and fibroblast growth factor receptor blocker. And others are trebenanib and cediranib. Bevacizumab is a humanized anti-VEGF monoclonal antibody used along with chemotherapy. They shrink and slow the growth of advanced ovarian carcinoma and improve progression-free survival from 3 to 4 and 6 to 7 months in platinum-sensitive and platinum-resistant and relapsed cases. So bevacizumab along with chemotherapy, that's carboplatin and paclitaxel, followed by maintenance therapy used. That is 18 cycle. And its side effects are risk of bowel perforation, hypertension, thrombosis, and proteinuria. Next is PARP inhibitors. They are polyadenosine diphosphate ribose polymerase inhibitors. Their enzymes normally help repair the damaged DNA inside cells. So proteins made by the BRCA genes also normally help repair the DNA. So mutations in BRCA genes hard for a cell to repair its DNA. So PARP inhibitors can make it even harder for the tumor cells with an abnormal BRCA gene to repair the damaged DNA and the death of these cells. So PARP inhibitors, which have the most exciting discovery in the field of targeted therapy of epithelial ovarian cancer, they are administered orally and well tolerated with least side effect and good progression-free survival. FDA-approved PARP inhibitors are olaparib, niraparib, and rucaparib. The SOLO-2 trial that demonstrated that the benefits of olaparib in recurrent epithelial ovarian carcinoma in BRCA mutated patients following platinum-sensitive therapy. Another two trials are NOVA trial and Ariel trial. In NOVA trial, niraparib is used and Ariel trial, rucaparib is used. They showed better progression-free survival benefit, which administered in maintenance therapy following good response in platinum therapy, respective of the BRCA status. In olaparib, there is used in recurrent high-stage BRCA mutation and epithelial ovarian carcinoma. They partially responded to platinum-based chemotherapy. It can be used as a maintenance treatment for advanced ovarian cancer, as gotten smaller in response to first treatment with chemotherapy. Niraparib and rucaparib are also used as maintenance therapy along with platinum-based chemotherapy. And Paula trial is a trial was to evaluate the effect of combination of PARP inhibitors and bevacizumab. And after this trial, NICE recommends the use of olaparib and bevacizumab in the first-line maintenance setting following good response to the platinum-based therapy in BRCA mutated patients. Next is the drugs that target folate receptor alpha. In ovarian cancer cells, there is high level of folate receptor alpha protein on the surface. So drugs that target this protein might be the option to treat these cancers, which includes mirvetuximab, soravtansine is an antibody drug conjugate, lab-made antibody linked to a chemotherapy drug. Inside the body, the antibody attaching to the FR alpha protein on the cancer cell brings the chemo directly to them. To treat the epithelial ovarian cancer that tests positive for FR alpha. So drug is infused into the vein and typically once every 3 weeks. Side effects are nausea, vomiting, loss of appetite, blurred vision, and neuropathy. Then drugs that target cells with NTRK gene changes, which include larotrectinib and entrectinib. They are targeted drugs that stop the proteins made by the abnormal NTRK genes. It can be used in people with advanced ovarian cancer whose tumor has a NTRK gene change and is still growing despite other treatment. It can be taken as pills once or twice a day. Next, last topic is immunotherapy. So immune system has its ability to keep itself from attacking normal cells in the body. So to do this, it uses checkpoints. The proteins on immune cells that need to be turned off or off to start an immune response. So cancer cells sometimes use these checkpoints to avoid being attacked by the immune system. So drugs that target these checkpoints can be used to treat some people with ovarian cancer. So epithelial ovarian cancer is immunogenic as immune cells active against the tumor and identified in ascites blood and tumor tissue. So immune checkpoint inhibitors are CTLA4, cytotoxic T lymphocyte associated protein 4, PD1, programmed cell death protein 1, and PLL1, so programmed cell death ligand 1. Which include a pembrolizumab. This targets PD1, is a protein on T cells that normally helps keep these cells from attacking other cells in the body. By blocking PD1, these drugs boost the immune response against the cancer cell. This can shrink some tumors and slow their growth. It can be used in advanced ovarian cancer that have high levels of MSI or changes in MMR genes, whose cancer starts growing after chemotherapy or other drug treatment. This immunotherapy drug is used as intravenous infusion every 3 weeks. Another drugs are avelumab, it's a PD1 inhibitor, and there is durvalumab, is also a PD1 inhibitor. Then next is adoptive cell therapy. It is an immunotherapeutic technique that uses autologous or allogenic anti-tumor lymphocytes to induce regression in cancer, which are less responsive or refractory to ICIs. So based on reinfusion of immune cells after stimulation, modification, and expansion in utero in order to amplify the autologous response against tumors. The tumor-specific cytotoxic T cells, they are isolated from the tumor or in the peripheral blood by leukapheresis, infused after leukodepleting chemotherapy. Thank you.
Thank you, Srilashmi. That was a wonderful presentation. It covered, I think, most of the gynecological cancers, including cervical and uterine cancers, etc. I think in adolescent group, the most difficult part is the diagnosis part. That if we see the ovarian cyst, sometimes the tumor markers may be elevated, and the cyst may be complex cyst or not, and that pre-operative diagnosis is very important. The in that cases also the TBS scan is very difficult in these patients. So I think we can do an MRI for getting a proper diagnosis, because I think most important thing is the solid component of the ovarian cyst. Whenever we come across the complex cyst or a doubtful adnexal cyst, put a laparoscopy and see what is the character of the ovarian cyst inside. And if it looked like a cystic part, benign disease, we can proceed with the laparoscopic cystectomy. If we see something inside a solid part, better to proceed by the USO without any spillage. The main part is to avoid intraoperative peritoneal spillage of the cyst or tumor. And the conservation also, like even if we come across the germ cell tumors, the most important part is the comprehensive staging. Usually we do the adenexectomy and amandal biopsy, but we have to take the peritoneal biopsies from the pouch of Douglas and the paracollicutus and the amandal biopsies. And we have particularly in dysgerminoma, we have to do the comprehensive lymph node staging also. There are many articles, like studies also, they say that there is no improvement in the overall survival, but definitely recurrences rates are more, because up to 30% dysgerminomas, there will be this retroperitoneal lymph nodes, because that staging is very important in the first surgery part itself, because in properly staged stage 1A dysgerminoma will not need any chemotherapy at the on the adjuvant part. So that part is important. For all other, even the overall the germ cell tumors, like even if advanced stage, that as Sri Lakshmi said, like we can consider fertility sparing surgeries. We can debulk the tumor to an R0. If the other ovary and the uterus is normal, we can do the adenexectomy and the debulking surgery, because most of these tumors are very chemosensitive tumors. So I thank the all organizers of this webinar, especially Anita Madam also, for inviting me as an expert to this webinar. Thank you all.
Thank you, ma'am. Thank you, Anu ma'am, and Sai Lakshmi ma'am, for enlightening us. I think with the advent of this targeted therapies, we have a new world in front of us to offer to our young girls coming with this gynecological malignancies, because it is not an end. I think diagnosing with a CA in a young girl, it's a huge burden to the family. But with this new advent of these drugs, we have a handful of drugs in our hands to offer, and I thank both of you for enlightening us of this. We have come to the end of our scientific sessions. I invite Mini Madam to express the vote of thanks.
Yeah. So, first of all, I would like to thank our dear President, Dr. Kunju Moideen. Sir has been the pioneer in allocating the webinars to each society, so that each society get turns, each society covers all the topics, and all the committees get equal chances. So well planned and executed, and very meticulous, and very much streamlined. Thank you, Kunjumadin sir. Thanks to Dr. Subhash, our vibrant secretary too. He's always at help to arrange a faculty, to arrange an expert. So thank you, Dr. Subhash. Thank you, Suma. Very good, Mosi. And Suma is also a very active member of Adolescent Committee. I know she is doing very well. So thank you, Dr. Suma, for doing the chairing and doing this Master of Ceremony. All society presidents have cooperated very well, and special thanks to the society presidents and secretaries of Trivandrum, Kollam, Adur, and Kottayam, Malappuzha, especially Anita Madam. Anita Madam, as always, every day she has kept in touch to arrange the faculties, the speaker, and Madam was very interested. And thank you, Anita ma'am. And the Madam of Kollam branch also has arranged faculties. Then our Sujitra Madam was the coordinator from the beginning, from the first episode. Now this is the 20th episode of this year. And so has always been a monitor and part of the events. Thank you, Sir Madam, all the best for being the next state president. And our three speakers, the young and energetic speakers, Dr. Apale, Dr. Sailan, and Dr. Anu, they've done a very good job and are the young talents of our society. Well done, and thank you very much. And I won't be doing justice. Madam was always busy, and Madam was Madam has always been busy with the young talent. In even she has been ready to grace the occasion as well as giving an expert opinion, and with a vast experience. Madam class very enriched with practical points. So thank you, Madam. Thank you, Sir, also for all the sideline help he has done for his faculties and the speakers. And also thank you, the oncosurgeon and for today. And once again, thank you for all the faculties, all the presidents of the societies, and also all the states that take part in this. So with this, great thanks, good evening and good night. Hoping to see you all in the state conference. Thanks a lot.
Thank you, madam.
Thank you,
With
Mini.
this, we come to the
Thank you,
end of the day. Thank you, madam. Thank you so much for sparing your time, ma'am, and for being with us till this time. Thank you so much, ma'am. Thank you, Jayasri, madam. And thank you, Dr. Anu. And thank you for all the presenters for a wonderful session. Thank you so much and good night.
Thank you.
the